Great. Welcome, everyone. Thanks for joining, especially on a relatively short notice, but I think this is a really important topic and a timely topic. So I'm Alex McDonald. I have the privilege of being your president this year. I'm also volunteering at the Emergency Evacuation Center in Pasadena right now at the Civic Center there in downtown Pasadena. So I have a little bit of real world experience right now. So obviously with disasters and with wildfires, it's seemingly occurringly happening more and more commonly. And I wanted to get us all together, and the staff from CAFP wanted to get us all together to talk about this amazing resource, the disaster crash cart, which was put together by the East Bay chapter after the Santa Rosa fires a couple years. And so Dr. Lassie and Dr. Ward from East Bay will share their experience there and put this in context, I think, but also share a lot of, excuse me, North Bay, I apologize, thank you. Wrong chapter, wrong location of California. We'll share some of their insights, and then we'll actually open this up for kind of Q&A and conversation, which is we want to do this as a meeting as opposed to a webinar. So again, I volunteered this morning at the crisis emergency center in Pasadena, and it's really pretty chaotic. It's I would say it's controlled chaos with the emphasis on chaos. It's actually originally was set up by the city of Pasadena, and they didn't do a great job doing infrastructure and logistics, and then the Red Cross took over, and so there's lots of people who want to help, but there's multiple roles and lack of communication, and things happen change so fast. And so this disaster crash cart is really kind of the one-stop place to provide quick and easy, accessible solutions and some common practices and principles that was learned from the North Bay chapter after the Santa Rosa fires. So all that being said, I'm going to turn it over to Dr. Lassie and Dr. Ward to kind of share their experience in putting this together. I have to apologize. I have to actually hop off and get my kids from cheer class, but I'm still going to be listening in virtually. So thank you all for joining, and I'll turn it over to you guys.
Go
ahead, Lisa.
Anna, maybe you want to start and like kind of talk about the process of how you developed the crash cart and kind of how you used it. That's kind of on the ground, and then I could do the kind of 5,000 foot step, which is sort of how we organize staff and how we staff the different evacuation centers. Does that make sense?
Sure. So we in Sonoma County were lucky enough to have not one, but two major disasters with huge evacuation centers stood up in the middle of the night in 2 years. So first in 2017, we had the Tubbs fire, which was kind of a huge wake-up call. And so I ended up that very first morning just going out to the couple of the different evacuation centers. And that fire, we had 2 of our 3 hospitals closed by the fire. And so a lot of people who were quite ill ended up in, I would say, challenging low resource centers like high school gyms and at the fairgrounds. And so I found myself first morning at one of the high school gyms. There were literally over 100 elderly, frail patients from nursing homes that had been evacuated into the gym, most of them without their medicines. We had people who needed oxygen, who didn't have oxygen. People were in bathrobes and slippers. And the Red Cross did a great job scrambling to get the gym open, to get cots and spaces like that, but didn't have any kind of on the ground medical care. And a lot of these people definitely needed some help. And so that's where this whole process of starting the disaster crash cart started. That disaster lasted for quite a long time. We had evacuation centers open for at least 2 full weeks. I can't even really remember anymore, but it was a long time. And our community health center had the place that I worked at and where we have a family medicine residency was also burnt. And so we had to scramble to figure out how to figure out what to do with residents, what to do with staff, all of that. And I'm happy to talk through a bunch more specifics about what we did. But so that was the first experience. And then 2 years later, we had the Kincaid fire that came in and again was very widespread evacuations, a lot of people. At that point, the county public health department had actually decided to transfer responsibility for the evacuation centers to our local community health center. And so I got tasked to go out to the evacuation centers on behalf of our community health centers and try to set it up, given what we had learned in the last time. And so it was the combination of those two experiences that led me to want to just write down some of the low-tech solutions to things that we put in place. And I'm happy to go through all of that. Lisa was at a totally different level, figuring out how to reapportion patients from the closed down health centers, how to work with the health department and the other, like Kaiser and other places, to provide the best support for all of the people in the county that needed help at that point. So I'll let Lisa talk about that experience a little bit.
Yeah, thanks, Pana. I think what we ended up realizing in those early days, what is that there's sort of a hierarchy of needs, and in the evacuation centers, there were, people who were from a developmental center that were institutionalized. There were these folks from care homes, and there were elder people coming from their homes who were very disoriented, coming so quickly and kind of alone. And then many people just coming from homes, as I'm sure you're experiencing. And so it became really clear that in that setting, there were the needs for sort of the medical care, and then there were needs for, I would say, great family medicine skill deployment and mental health deployment. And so what we did was we created two kind of core things. One was teams of we had the great richness of we had residents and faculty and like really 150 medical providers who needed something to do and had amazing skills to use. And so we created small teams of behavioral health providers with family physicians and nurse practitioners who went into and basically staffed the shelters actually for 24 hours a day for some days, but also I think fewer shifts than that for the less acute places could be adequate. But the point being that these teams went in, both behavioral health and primary care, family physicians, and did triage and identified medications needed. And the second pillar of that was that Kaiser, the big systems in our town, so Kaiser, and the community health centers in particular went in, and we just used mobile, laptops, and we used the connectivity of our health record, and we basically, refilled medications, particularly like insulin and opioids and benzodiazepines, and, thinking about what are people going to suffer most from if they don't have them in a timely way? Blood pressure medications, other diabetes medications, and then just the respiratory illness, and people needed help responding with medications for respiratory illness, and then the both somatic and just the like intensive stress responses that they were having. And so those were kind of like the big three buckets, I would say. And we literally just did essentially in person, on the fly, clinical visits for hundreds of people day in and day out for at least 3 weeks at some of the shelters, and just were there present in a very mobile way. And that helped people I would also just add there are people coming in and withdraw after they've been in the shelter. So just, those are the kind of issues that are going to come up. And we just brought the care to the people and used connectivity to pharmacies to help them like bridge their care until our healthcare system could get back up and running. So that's sort of the setting that I think the shelters are potentially in right now. Do people have questions for us? Is that the next step, Alex, you would like to do? Or could we maybe open it up for questions?
We will take questions if you can raise your hand, and then we can unmute you, and I'll let you know, Lisa and Pana, when the who it is that's asking the question. We're going to do that just to ensure that we don't have any unwanted video guests.
And then it looks like we can look at questions. And I'm just going to check the chat too and see if there's any questions there already.
I'm looking at the chat. I don't see any questions. It says, sounds like we addressed the 3 S's: staff, supplies, and structure needed in disasters. While we're waiting for, I see Nalini has a hand up.
Hi, everyone. Sorry, I was just waiting for others, the physicians to ask questions. I'm not a physician. I'm a computer scientist, and I lead a project on looking at older adults in disasters and looking at, information that can be collected that can help better triage and safety of such patients. I'm curious, in this situation, did you run into people who needed dialysis, and how did you resolve that situation? And because some of these things can be needed pretty quickly, right? And the second type of patient that, I was also curious about, whether they came into shelters is another question, is those with dementia and Alzheimer's, and how did that work?
Maybe I'll just take the dialysis question and then Pana let you take the one about dementia. So the dialysis patients at least to my knowledge, didn't typically come to the shelters. And Pana, you may have some exceptional examples, but I think what happened is that the dialysis centers like triage their own patients and move them to places where they got dialysis. And so I don't think many of those folks actually came to the shelters. You may have them in your shelters, but in our shelters, I don't think that's not who we saw. What did you see, Pana, from your memory?
There were a few, and mostly like they were able to arrange transport to where they got dialysis. So there were a few. It wasn't a big issue because there were dialysis centers still open in our town. We had lots of people with Alzheimer's and dementia. That was a huge number of people, and it was challenging. I mean, I don't have a real answer for how we dealt with it. Oftentimes they would come, like if people were still living at home, they would have their partner with them, which would be particularly hard on their partner because then they couldn't like go to the bathroom and leave the person who might wander on one of the cots. So we tried to identify those people who needed particular protections, move them closer to where our medical area was. So we sort of tried to set up the cots in the gym or the giant pavilion in the case of the at the fairgrounds. We would sort of hold some areas close to where our medical area was so we could keep an eye on the most fragile or likely to wander people. So I don't know if that answers your question. I did see a question in the chat about verifying medications and doses while prescribing. So, some of the places that we work did not have any internet access at all. And so we really couldn't verify people's medications at all. I did, like I would find out somebody was it Kaiser or was it Santa Rosa Community Health, and I would literally on my cell phone call my friend who I know worked at that organization to look up their meds if they didn't have they didn't seem to know what they needed if they weren't sure. And then in the disaster crash cart, refilling people's meds is like a whole process in there because they need their meds, they've lost them. And so a lot of times people just know their meds and they're not anything that I would worry too much about, like I'm going to give them the wrong dosage or start somebody. I wasn't starting anybody on narcotics or anything like that, but just refilling people's routine meds. We would actually have, and it's in the disaster crash cart. I can show it to you. No, I can't share screen. Oh yes, I can. Let's see. I can pull that up while we're talking about something else. But
It was almost like a list, almost like a very short, like personal medical history that we would gather from the patient themselves.
right.
And then the other thing we did was the patient knows what pharmacy they go to, or even what commercial brand. It doesn't have to be Rite Aid in Pasadena. If they just know they get their meds at a Rite Aid, you can call the Rite Aid. And in the setting, once a disaster status is called, the rules of pharmacy prescribing actually loosen up and change. And so the pharmacies themselves have more latitude to fill medications for patients they're not aware of or not registered at their particular site. And so there's just a lot more flexibility, and the PARs and the TARs and all that stuff goes out the window because people just need their medicines. And so it becomes much easier on the administrative side at the pharmacy to fill meds.
Yeah, there is a specific code that I can't remember off the top of my head that is the emergency code for pharmacy refilling and not charging people an extra cost. And I'm just going to share my screen so you can see this. It's very simple way to get the medicines that people want, and then you have them fill this out. You split it up into 4 little pieces of paper, have them fill it out, and then we would call those. We'd have somebody who would call in all of the medicines if we couldn't get the pharmacy to just refill them. And then we had a runner go pick them up. And then we stapled these little things to the top of each bag. And then we went around and delivered them in the shelter. And so you can see that's why it says location in shelter, which is something for those of you who are working in the shelters. I would encourage you to do something really basic to divide up the shelter into sections. So even if it's just like we put A, B, C, D, E, F all along the pillars in the pavilion, divided it, put tape down on the floor, divided it into 1 and 2. So somebody would be in A1 and A2 and B1 and B2. So it made it easier to go find people in the shelters to give them their meds afterwards. I saw some other questions in the chat. How did we verify med doses? I think we just talked about that. Liability coverage. Lisa, want to take that?
Yeah. So, I think I can't speak to the way the liability coverage works for other health systems, but for the FQHCs, like our FTCA insurance covered us to be providers providing care for our patients. So we didn't cross-pollinate in the sense that when our teams went to the shelters, for the most part, we weren't taking care of Kaiser patients, but Kaiser deployed their own teams and they would go take care of their Kaiser patients. So the systems made the health insurance, the liability insurance portable with the teams. And then I can't say, so I think that like the liability coverage that you already have will support you to do the care that you're doing for your own patients. I think it was tricky because there's also patients there who, it doesn't cover everyone. Like there were patients who weren't in our system, so we didn't have a lot of information about them, but we were still able to, for example, get medications from their pharmacies and use the techniques that Pana already talked about. We didn't ignore them and not do anything, but but I don't know how the liability would have worked. I suspect in the setting of a disaster, there's a lot of latitude that as a physician practicing within your license and your scope of practice, if you're doing that type of care in a disaster, I would guess you have a high level of protection, and I didn't worry about it too much, but I could not tell you the details or the policy around it.
Yeah, and we can try and get that information for you and put it up on our website, or if you send us an email at cafp@familydocs.org, we'll try and get you some follow-up information. It looks like Dr. Robinson had her hand up next with a question.
Thank you, and thank you for sharing your experiences with us. I think many of us are still in shock from what's happened here, and have so many people that we work with who've lost homes, and I'm the chair of family medicine at USC. We're just trying to check on everybody and make sure that everyone is okay on our team. And so I don't know if you all have any sort of guidance or advice about, how to be helping your workforce through this challenging time, as well as being there for the patients that need us too.
Yeah. I guess I would start by saying that, as you know, the situation is very fluid, and it could be fluid within the day or within the half day, or eventually it slows down and you can be a little less fluid and dynamic. But I think on the sort of technical side, we really did keep a running count. There was like a group of people that were from operations, and they really checked in literally staff member by staff member, probably twice a day in the early weeks, to just say, kind of, how are you? Do you have your home? Like, where are you? And also like things like we had staff leave because their family's home burned down, but their home was safe. So there were people helping people, which impacted our workforce and our morale. And so I think the check-ins just to help you to connect with people and just give people grace, like, oh, you're in the evacuation zone now and you need to go check on your house or get your cat, go. Like there's no, like, it's just this supportive way, like come in and help us when you can. And when you can't and you need to go save something for yourself, go now, support you to go do that. And then just multiple check-ins in the early days. And then as it slowed down, we just had like kind of grief sessions, and we had like rooms with circles of people in them. And we all just, talked about our gratitudes and talked about the heroism we saw, talked about our losses, talked about like things that were shocking and egregious that felt really like kind of moral bruises that were going on. And sort of just had over time, slowly, these kind of peeling away and being present for each other.
I think that's great, Lisa. And I would also add two things. One is I feel like there's kind of two types of people in a disaster. Those who turn outward and want to jump in and do something, and those who turn inward and want to protect their family and, take care of all of that. And I think just trying to support both of those people is really important. It can be like talking about the heroism can be hard on people who are really just trying to take care of their family, who's having asthma or whatever, and talking about, you know, taking care of self can feel really tone deaf for those people who really just want to jump in and fix it. So just recognizing that that duality exists, and like Lisa says, it changes over time. And then the other thing, because I don't think we'll probably do this again, one of the things that I found helpful, and I know a lot of people found helpful, was the graph of sort of how the community feeling in general tends to go. So in the beginning, you know, everybody's a hero. We feel, you know, Sonoma strong, the love in the air is better, is stronger, is thicker than the smoke. Right. And then it drops off and everything sucks. And it's just this horrible place that you're at where nothing is good. And then it comes back up. But it takes like a year before people have sort of recalibrated of that whole roller coaster. And I think Lisa's looking it up so she can share it. But it is really helpful to have that frame to recognize what's going on. And I do want to say, just share for you guys, I was reflecting as I drove through Coffee Park the other day, which is the area that was so badly impacted by the Tubbs fire, how you cannot even tell that there was a fire there anymore. It looks just kind of normal. And so if I didn't know that that had been a smoking ash pit in 2017, I would not know. So there is hope. It will get better. It won't look like this forever.
Thank you. That's very helpful. I appreciate your perspective. Thank you.
Dr. Hernandez has patiently had his hand up for a while.
Hi, good evening. Can you hear me okay?
Yes.
Yes.
Thank you. Thank you very much for making the space and the time to kind of share your pearls of wisdom. I'm the Associate Program Director at the Ultimate Family Medicine Residency in Southeast LA. And we've been kind of helping out along with Kaiser over there at the Pasadena Civic Center. And so we've definitely been seeing a lot of the things that you've been touching on have been very, very helpful. So I guess there's two questions. Number one, I don't know, is the kind of the crash cart information going to be shared, and where's the best way to look at that? And then I guess my second question would be is what suggestions would you have at this moment in like setting up a medical kind of section in the kind of a big kind of arena when it comes to having multiple parties like Kaiser or other organizations and community health centers? What kind of layout would you recommend in this situation?
So the disaster crash cart is available. It was in the chat. Oh, Josh just put it in again, and that's in like a PDF version. It is still on the internet because I haven't taken it down yet. www.disastercrashcart.org.
And it's also on the CAFP website.
And also that's where the link that Josh put in is at the CAFP familydocs.org website. I will I think maybe it might help just to show you guys briefly what's in there. Let's see. So I'm going to share screen again after I move the chat. Okay. And
while you're doing that, we did have a question in the chat. Can you talk about other ways family doctors can help? Not everyone can volunteer or take time to help in a shelter.
So in parallel to what's going on in the shelters, for the health centers that are up and running, you know, those health centers are still playing this kind of complex game of Tetris around trying to see like which patients come in. You know, health centers and probably are strategically just becoming kind of walk-in centers because no-show rates are high, but there's spontaneous need that's also high. So within your own health system, just doing your work as a family physician is incredibly helpful. I also think that within your systems, there's a lot of work that can be done that's more think like population health based. So our health systems really want to identify who are all those women who are high risk pregnancies and women whose pregnancies are like 35 or 36 weeks. And, get those medical, contact those women, figure out where and how they are, and get their medical records to the hospital where they're more likely to be delivered if their hospital isn't up and running. Controlled medications. Our health systems can identify those people who are due for controlled medications and connect them to pharmacies that are willing to fill them so that they don't go into withdrawal. We can identify our diabetics and make sure that for those people who have diabetes and are on insulin, we get those important medicines to them. There's a lot of like registry type of work that you can help.
Oops, we lost her. I think, there's a lot of thinking about the other thing that was very useful is like looking ahead at who had appointments to come in, and were any of those really urgent and needed to be rescheduled. If somebody they're just, you'll see when you're looking, scrubbing your schedule, that there are some people you're going to have to send somewhere else, and so there's a lot of collaboration that can happen. There was questions about how to set up the medical area. So this is what the pavilion that I've mentioned a couple times looks like, and I think it's probably similar to what it sounds like is being in the in LA area. So, first things that you should know about if you're going into these settings, you want to know who is running the shelter. Is it the county? Is it the Red Cross? And who is the shelter manager? And who is in charge of facilities? And is anybody being in charge of access and functional needs? And so that is often different groups, and you want to kind of make a list and know who's running your shelters. And then sort of try to set up a regular daily meeting with those people so that you can all work together better. And then just thinking about the simple physical space, it partly depends on sort of what you have available. But like in the most basic, you just got a big giant room and it's all set up. So you've got your check-in table and lots of cots, and then you save the cots by your medical area. You want to get some screens so that people can have a place that's private so they can show you their oozing abscesses or whatever it is. And then like a couple chairs and a place for somebody to sit. Basic supplies like Tylenol and Tums and stuff like that so that you can give those out, and a couple people working back there. It's good to site your medical area close to the bathroom because oftentimes people will need, to do a pregnancy test or to, all of these high needs people that are close by your medical area will need to be able to access the bathroom pretty quickly. And then if you have a more complicated setup, like somewhere where you might be able to actually have, an exam room, an isolation area, this is things that you're going to want to think about, a place for the staff, a place to triage. And then if you can and you have the need for it, it's great to have a separate sort of, for lack of a better word, like a mini hospital area where people can get get more more support and have somebody around. Oh, I thought I had a picture of that, but I guess I don't. So I don't know, the different, the direct observation ward, I guess that's what you call that. And then isolation for when people get norovirus. which if your shelters are up for more than a few days, probably there will be a noro outbreak. So just start thinking about that so that you can isolate people and not have that spread through your shelter. And then I think we talked about that. One thing that I would really strongly suggest is having a phone for each evacuation center on the medical area so that you can coordinate with other places that, like if there's another evacuation center nearby and you might want to share things or share volunteers. If you get yourself a burner phone, oftentimes AT&T or Verizon will be around giving out burner phones to people. Get one for your, and leave it on that table or put it in like the main person who's managing things pocket so that you can communicate back and forth. People can call in to the shelter to say, you know, should I bring adult diapers? Whatever it is that you're trying to get, you'll have a centralized place to communicate. And then, you know, if you don't have Wi-Fi, but there is cell phone coverage, you can use a MiFi device or another kind of personal hotspot that can be shared with a bunch of people. And that can be super helpful. So I'm just going to show you, so on the web, the disaster crash cart, there's stuff about the medical area. There's basic charting. Really, we used these plastic boxes to just keep medical records on the people in the shelter because we didn't necessarily have the computers. And there's basic progress notes, medical lists. You're going to have people who just need a nebulizer treatment or just need a Tylenol, and you want to just be able to write their name down and what time they took it. So there's a little form for doing that. If you have a lot of really sick people and you can get some kind of a computer, you can use an Excel spreadsheet to track those people. And then managing volunteers, the Sign Up Genius is incredibly helpful for managing volunteers. We had a huge problem where, you know, usually around 10 o'clock in the morning, there'd be 20, 30 people showing up and wanting to volunteer. And we had lots of people already. And come 8 o'clock at night, there's nobody. And so trying to get people to sign up for shifts in advance also makes it possible for you to check their medical licenses and make sure that their licenses are up to date and that they are who they say they are. And then when they arrive, you know how many people are coming. You know whether they're family docs or ENTs before you start sending them out to check on people. All of that stuff can be kept in the Sign Up Genius, and there's a template there. And we found that to be really helpful. And then, of course, if people are signed up with the Medical Reserve Corps or disaster healthcare volunteers, that's an extra level of helpfulness. The Red Cross really appreciates those folks. Okay, I'm going to stop talking. Oh, one thing I did hear about residency programs. So we did use our residents in the shelters. We made sure we had a faculty person available for them to touch base with and you know, we're able to take care of patients safely that way. And then there's just some stuff about the institutional requirements that can be waived during disasters for residency programs. Okay, I'm going to stop sharing.
All right, sorry folks, I'm back. Even in not in a fire zone, I lost power on my computer.
Well, we don't have any hands up and it doesn't look like we have other questions in the chat. As a reminder, this resource is available on the CAFP website. There's also a link and the alternative website that Hannah offered. Please also know that CAFP is a resource. I did remind everyone that if you know of anyone, for example, that needs temporary housing, you are family physicians, and I can't tell you how many calls and texts and emails I got saying, if you know anyone who needs a room with a family physician, and it is member to member, so there's some sort of at least screen there, but we're more than happy to connect you. So please don't hesitate, particularly for medical students and residents who might not have the same kind of network here. We did put that out to them, but like I said, if you hear of anyone, you can call or email for them if they're feeling a little hesitant to do that. We are working with the AAFP and a disaster relief organization to try and get some supplies to some physician practices. I know we've been working with USC with Dr. Gibbs and Robinson for their street medicine team to try and get some masks. I will say we aren't getting them as quickly as we would like, but if you need supplies related to disaster or personal hygiene kits, please send us an email again at cafp@familydocs.org, and we can at least try and get those to you as quickly as possible. Well, once again, I just want to thank Doctors Lossie and Ward for being here tonight and sharing experience and kind of what you went through with the fires in Santa Rosa, and for having the foresight to prepare the disaster crash cart so that it was ready when our LA members and others needed it. So just huge thank you to you. And we, of course, your CAFP staff are thinking of all of you in Los Angeles and those who have come to help. Keep checking in. Don't hesitate to let us know if you need anything. And I know you have colleagues, including our two presenters, who are more than happy to talk. And even if that is about something that's not patient related and you just need to kind of think about and talk through some of the different scenarios, we are here for you, and your colleagues are too. So do let us know how we can be helpful, and go to our website, download the app. We'll continue to push out information there as well.
Good luck, everyone. It's a really hard position that you're in right now. So we're kind of feeling and happy to be of any help we can be. So please raise your hand or reach out to us.
Thank you. Good night, everyone.